Hello, I'm Bill Balistreri, professor of pediatrics at the University of Cincinnati and Cincinnati Children's Hospital. We are here today on Medscape via Skype to discuss the recently published recommendations for the diagnosis and management of gluten-related disorders in children and adolescents. Let me first introduce my colleagues. Dr. Alessio Fasano is the W. Allen Walker Chair of Pediatric Gastroenterology and Nutrition in the Department of Pediatric Gastroenterology and Nutrition at Massachusetts General Hospital, Harvard Medical School. And Dr. Ivor Hill is Professor of Clinical Pediatrics in the Department of Pediatric Gastroenterology at The Ohio State University College of Medicine. So to begin the conversation, Dr. Hill recently assembled a group of experts on celiac disease in order to offer guidance to clinicians in their efforts to distinguish celiac disease from non-celiac gluten sensitivity and other disorders such as irritable bowel syndrome. So Ivor, could you please summarize your approach and underscore why it is so important to accurately differentiate these disorders?
In essence, we wanted to distinguish between celiac disease, wheat allergy, and non-celiac gluten sensitivity. And the importance of distinguishing between the three is, for a start, if you have celiac disease, it carries certain implications for long-term adverse health outcomes, and also for certain follow-up that we need to do. If you have wheat allergy, it means that it's a less restrictive diet you would have to follow, and that there's a good chance that you could actually recover from wheat allergy. And then this entity of non-celiac gluten sensitivity has become a very hot topic. We're not sure exactly how many people this involves, and we think that it may be a collection of different things that people are responding to when they remove gluten from their diet. But the importance is to distinguish between the three, because it does dictate how you're going to manage those patients and what the long-term potential outcomes are.
The clinician out there who has a patient with GI or systemic manifestations, how do they approach this patient, this child?
Right. So very important to understand is there's significant overlap in the presentation of the symptoms of all these three conditions. It's really important to try and identify specifically which it is. We would strongly recommend that if you have a patient who you suspect has one of these conditions, that you first test them before you treat. The tests for celiac disease are pretty specific. We would recommend using a tissue transglutaminase together with a serum IgA level, and if that is elevated, to go on to do a biopsy to confirm celiac disease. Wheat allergy is a little bit more difficult. You can suspect that there are skin prick tests that can be done for wheat allergy. They're not terribly sensitive or terribly specific, but often it means that you have to do a food challenge to diagnose them. Non-celiac gluten sensitivity is really a diagnosis of exclusion. You have to exclude celiac disease. You have to make sure you don't have wheat allergy before you consider the diagnosis of non-celiac gluten sensitivity.
So you made a point that all of this workup leads to an intestinal biopsy. Our colleagues in Europe have discussed the potential of making the diagnosis without a biopsy. Can you give us a little bit of insight?
Yeah, so we're still a little bit concerned about not doing a biopsy in the United States. For a start, the recommendations from Europe are that if you had a tissue transglutaminase level that was greater than 10 times the upper limit of normal, a second test showing a positive endomysial antibody together with the correct HLA DQ2 or DQ8 haplotypes, that in the symptomatic patient you could then make a diagnosis confidently of celiac disease. In the United States, we're concerned that there's no standardization of the tests for the celiac serology, so there's quite a little variability between the various companies that offer this test. And we still feel more comfortable in using a biopsy to confirm the diagnosis. I think it's important to confirm the diagnosis because you really are subjecting that individual to a strict gluten-free diet for life, which carries a lot of implications in and of itself.
Well, that leads me to Dr. Fasano. Concerns have been raised about the lack of effective long-term management programs to optimize the treatment of patients with celiac disease. For example, recent reports indicate that optimal follow-up and care of subjects is not driven by evidence, but largely based on perceived benefits. You know, we all have these ideas in our mind. So last month, Dr. Fasano and colleagues published a report on evidence-informed expert recommendations for the management of celiac disease in children, in which they address these questions regarding which tests and practices should become standard of care in regards to management and monitoring. So, Alessio, could you review these recommendations for us, please?
First of all, this was the work of love of the late John Snyder that unfortunately left us prematurely. But, he was the one that assembled this group of individuals based on the clinical sense that this recommendation for managing celiac disease was long due. The fact is that, again, there are, discrepancies and not unified way to approach the management of celiac disease in children. And therefore, we eventually decided to sit down and focus on specific 6 categories, mainly bone health, hematological issues, endocrine problems, liver disease, nutritional testing. To do so, we went through the literature. We reviewed 600, publications, and only under 72 were deemed to be, appropriately designed to be included in this, evidence, based expert recommendations. And this was developed, by an expert panel that was assembled. Of course, as all the conditions when you don't have, guidelines, but, expert recommendation, there could be some discrepancy among experts. But surprisingly enough, out of 25 questions, 24 were unanimously answered in a blind fashion by the experts. So there was pretty strong, unanimous recommendation, the way that we perceived the evidence are there and the appropriate recommendation. And again, without going too much in details, in terms of, bone health, there was no initial evaluation, for example, for routine screening from bone health. And we consider, after discussing that, the grade of answer was moderate and the strength of statements that we made was kind of weak. While on the other hand, for example, provide the counseling of age-appropriate intake of calcium, vitamin D was very highly regarded, and there was a strong recommendation there. And the same applied, for the hematological domain, in which the screening for anemia was highly recommended and with strong evidence. Why, for example, folate deficiency was very low evidence and weak recommendation on the matter. And initially, even the NIH consensus conference really created a kind of discrepancy of what the recommendation was put on the table at that time, i.e. to not screen for celiac disease people with type 1 diabetes, while we concluded that the evidence is extremely strong. In terms of liver, routine screening for LTST was highly evidence and moderate recommended. And for hepatitis B virus immunization status, it's another major issue that we deal with. There was definitely a recommendation in that domain. We spend most of the time, and most of the controversy were on the testing. And again, while the TTG is a robust diagnostic test and is validated and accepted by the FDA, we concluded that in terms of monitoring, unfortunately, it does not have that kind of strength that we perceived at the beginning. And the studies are coming up in the literature seem to suggest that that's the case.
Well, Alessio, I was surprised because many of the practices that we had established in our own world were not supported by the evidence. And I think this document will provide some very useful guidelines, hopefully will allow us to follow these patients in a very cost-effective manner. Now, I know, Ivor, you and your colleague wrote an editorial in response, and so perhaps you could end this section by giving your perspective on these recommendations.
To me, the strong thing that came out of this publication was that it is more likely to standardize care. I think if you look at the care of patients with celiac disease, both at the time of diagnosis and subsequently with follow-up, even amongst our own division, which is a very large division at Nationwide Children's Hospital, there's extreme fragmentation of care. It's not uniform at all. This publication gives us a basis on which to standardize care, which I think will lead to improved outcomes with our patients with celiac disease. It really has been very useful so that we know what to do at the time of diagnosis, which tests we should do, how often we should follow these patients up, which tests should be done at follow-up, both at the 6-month and the annual visits, and I think it will improve the long-term outcome of these patients. So it's a very, very important publication from my point of view.
One of the questionable areas was the, as Dr. Fasano mentioned, bone health. And, we routinely would measure bone density and all of the associated minerals and vitamins. And your recommendations have really allowed us to cut back and I believe to be cost effective. Alessio, what was the most problematic area for your group, the one that had the least evidence yet probably the most attention in clinical practice?
Well, definitely was the testing. As I was mentioning before, we always use the TTG both for diagnosis and management with the understanding or the perception that it's as robust in both domains as we anticipated. And honestly, both this review and then again, evidence that are now coming up seems to suggest that the TTG antibodies is undisputably one of the most formidable tests that we have in our toolbox for the diagnosis in terms of sensitivity and specificity. There are very few tests that are as good as the TTG. However, when you use that for follow-up, the discrepancy between what we see in terms of the the test and the actual repair of the celiac enteropathy becomes wild, and so much so that now again we have to review our way to manage kids with celiac disease. And again, our concern now that we just published recently is that up to 20% of these kids would not repair after a good year of compliance to the gluten-free diet, despite the TTG is negative. And we don't know what kind of consequences these kids they can have, particularly in terms of growth in such a crucial time of their lives.
So what's on the horizon, gentlemen? I know in real life the patients who are extraordinarily sensitive to gluten are inadvertently exposed at various times. So is there a way to either monitor the dietary intake, to have a gluten-sensing dog, or fecal antigen tests, or some way that we can prevent these children from getting into difficulty? That'll be our final comment from both of you.
I think Alessio makes a very strong point about the fact that we just don't know how many of our children are repairing completely from the villus atrophy. And I think this has opened up a whole new can of worms and something that we need to start looking at in the future. Are we following these children correctly? Are we monitoring them? Because there's no doubt about it that the long-term adverse health implications that are associated with celiac disease are not related to symptoms, they're not related to persistent TTG, but they are strongly related to persistent villus atrophy. So that's number one. There was also a very interesting paper that's just come out in the American Journal of Gastroenterology, where this group from Spain, I think it is, have been looking at gluten immunogenic peptides in the stool and documenting that you can actually identify these in the stool when people think, based on a dietary review, that they are completely gluten-free. So that may be something in the future that will give us a very good test, and I'm kind of excited about this possibility, that we'll actually be able to detect gluten immunogenic peptides in the stool and know that the patient is still being exposed, as opposed to relying on dietary review and symptoms and TTGs.
Well, thank you, Ivor. Alessio, final comment?
And just to echo what Ivor just said, again, we really do have concern here. This same Spanish group that Ivor was alluding to present a follow-up, evidence of the robust, performance of this test of immunogenic peptides in stools at the World Congress that we had in Montreal. And I'm also impressed, as Ivor, that this could be definitely a very objective, strong monitoring of inadvertent exposure to gluten. There is also, a strong effort to develop devices to check for possible cross-contamination in food while you go out for dining and so on and so forth. The MIT put together these microchips that is quite interesting to me. I have, mixed feeling, that when you go to have a meal, that you have to sit and wait for 10 minutes before figure out if it's safe for you or not. But if they, as this looks like, they can bring that down to real time, I believe that will be a major advance because, of course, this inadvertent cross-contamination that don't occur home, people, they know what they're doing. The problem is when you go on the road and, again, some restaurants, they offer gluten-free meals. They may not be as careful as it should be because now this is perceived to be a fad and and they don't understand that this is a medical necessity for these people.
Well, thank you. On behalf of WebMD, I want to thank Dr. Hill, Dr. Fasano, and all of you for joining us. Thank you.